Part 2 is called Normal Aging and Dementia, Telling the Difference and Taking Action. And so I'm going to share with you the objectives. They're very straightforward. We're going to discuss why detection of cognitive impairment is improved with the use of validated tools. I'm going to show you how to use and score and interpret 2 different detection tools called the AD8 and the Mini Cog. And then after lunch, we're actually going to, as I mentioned earlier, use some time to practice, getting used to being the client on the client side of things and on the administrator side of things, and doing some scripting, okay? So using validated tools, I want you to know something very important, which is that we are all unreliable observers. Even dementia experts do not reliably pick up on early signs and symptoms of dementia during a conversation. Now, why would that be? Why would even people like me, I've been working with people with dementia for over 20 years, why can I sometimes not tell the difference of who's impaired or not in a clinical conversation of 10 to 15 minutes? Any guesses? Symptoms are so similar to what? All the different types of dementia, but how about just telling the difference between normal and not normal? Why is that so hard in a conversation? Because of ageism, sometimes we think, oh, these little lapses are just normal. Well, the other big reason is that we have all been talking and bantering back and forth in social discourse since we were 2 years old. Language, communication, conversation is a very deeply embedded skill. And so in early dementia, there may be occasional word-finding difficulties, but they're not prominent for most people. And so people with early Alzheimer's disease can talk, walk, chew gum, carry on a conversation, appear pretty normal. And so this interaction that we have conversationally is not an appropriate way to detect who is impaired or not. In fact, I can't tell you how many times personally I have been fooled. I will talk with a family member or a patient for 30 minutes and then think to myself, I think she's pretty intact. And then we move to do the Mini Cog or some of these other cognitive tests, and the bottom falls out. So don't be fooled. We are not good detectors. Validated tools like the Mini Cog and the AD8 are supported by decades of research. What happens is that thousands of older adults are given these tools in addition to a physical exam, a whole Cadillac medical workup to determine the nuances of who's impaired or not. And then the tools are refined and refined and refined so that they are short and very, very sharp in their detection capabilities. And so the message here is trust the tools. Trust what the tool is telling you. If you have a conversation, do an assessment, and you think this person is fine, but the Mini Cog tells you there's a problem, which are you going to believe? Don't trust yourself. And I'm going to show you a graph that proves this point. On the lower part of the graph, going left to right, are stages of impairment. So starting with mild cognitive impairment, mild, moderate, and severe dementia. The yellow bar is a doctor's ability to accurately say yes or no, this person is impaired based on a clinical interaction, a conversation. The green bar is the Mini Cog's ability to accurately say yes or no, this person is impaired. What do you notice? The Mini Cog is always better. The only time where the Mini Cog gets close to the physician is in severe dementia, when you don't need an MD, a PhD, an RN, or an MSW to tell that there's a problem, right? But before then, these validated tools give you accurate information, so trust the tools. So before I give you some specific information about how to use these tools, I want to give you some overarching general tips and tricks, do's and don'ts, if you will. So it's important that anytime you use these types of tools that you set the stage with a relaxed demeanor. Now, one aspect of the brain that is typically well preserved in Alzheimer's disease and other dementias, as you heard Wendy Mitchell say in the beginning, is emotions. So people with dementia are even more attuned to our emotional state than we are with each other. It's a hyper attunement. And so it's extremely important that when you're doing these tools, you're nonchalant, carefree, you don't make a big deal out of them. They're just standard practice, just like anything else. Because if you have anxiety, trepidation, discomfort, I guarantee you that the person you're working with is going to pick up on that, and it could impact their willingness to comply and their performance. Point number 2, do whatever you can to minimize sensory problems. So if the person has glasses but they're not wearing them, ask them to put their glasses on. If they're hearing impaired and they have hearing aids, ask them to put their hearing aids in, even if it takes 5 or 10 minutes. You don't want hearing or vision loss to be the reason why someone is not performing well on these tools, right? So do what you can. You're also never going to utter the words test or memory. And you're certainly never going to say, next, I'm going to test your memory. Why are you not going to say that? The words test and memory raise people's blood pressure 20 points right on the spot. You don't want to increase anxiety. It's not necessary. So don't do that. Just say, the next thing we're going to do requires a little concentration, because what you want to do is make sure that they're focused on you. And so using that phrase, the next thing we'll do requires a little concentration, is enough to prime them to focus. Throughout this evaluation, you're going to maintain this easy breezy attitude. Now, you're going to do this even if someone performs horribly. So in a minute, I'm going to show you this clock drawing test. And even if someone does really, really badly on that, you're not going to allow your facial expressions to show what you may be feeling. Don't do that. You're going to just be easy, breezy, relaxed. It's going to be okay. Now, this seems dumb to emphasize this, but this is a very important point. Because people with cognitive impairment, Alzheimer's disease and dementia, are so attuned emotionally to what's going on around them, your facial expressions are very, very key to this process. In fact, they're a golden key that will help you through many sticky situations. You should smile openly and freely and do whatever you can to have just a really inviting, nice facial expression, because it will help you and the client to navigate through this process. And first and foremost, don't be a robotic administrator of an assessment. Just be a person. Listen, talk story, be empathic, and you'll have a good experience. It is also very important that you be gentle but persistent if a client gives you a little bit of grief or resistance or wants to put the brakes on. Now, when I was in training at UCLA, I had to give all of these tests, brain tests, for these patients who were in investigational drug trials. And one of those tests involved asking people to count backward by 7s from 100. Everyone's favorite thing to do, right? And so every time I got to that question, bless you, every time I got to that question, what do you think happened? People said, I'm not going to do that. I can't do that. I've always been bad at math. So what I did initially as a trainee was that made me anxious. I didn't want to make them mad, and so I just skipped that question and moved on. After doing 20 or 30 of these, my supervisor, a neurologist, came by and said, Terry, we're missing a lot of data. What's happening here? And so he shadowed me and sat in and said, you know, I think that you're giving up too prematurely. Watch me. And he modeled what to do. What he did was very simple. He joined with the dissatisfaction of the client, validated their feelings, but pushed them to continue. And here's how he did it. He would laugh and say, yes, this is kind of a ridiculous question, isn't it? Let's just try it anyway. What's 100 minus 7? And you just keep going. And what happens? People do it. So this is a true fact, knock on wood. In the 22 years since I got that mentorship, I have never had a person refuse to do that for me. Not ever. So what does that tell you? It's not about the people, it's about you. And I share this story to help you be confident and move forward. Don't be derailed by a little bit of, oh, I don't like that, I don't want to do it. We're going to do it, and we're going to put a smile on our face, and here's the next question, okay? Don't offer feedback of any kind during the screening, positive or negative. Don't say, that was great, good job. Why not? Because even positive feedback communicates something. I'm critiquing you. This time you did a good job, next time you may not. So don't offer that feedback. Now, this may be the simplest thing or the hardest thing for some of you, because it's normal to want to give that kind of feedback, but bite your tongue, close your mouth, try not to do that. If you need to offer feedback, just say something like, that was fine, and the next question is this. That was fine, you're doing fine. Okay? That's much more neutral. Don't allow people to give up prematurely or skip questions. If you allow people to skip questions, at the end, you're not going to have a total score. And without a total score, the instrument may not give you the kind of information that you're hoping for. Don't deviate from the standardized instructions. Now, this may also seem a little silly, but there's a volume of research that could fill this entire room about the ways that people say things a little bit differently off script and how that changes people's performance. In the research world, this is called something, and it's called radar drift. Radar drift. So today, all of us are in the same raft together, okay? I'm steering the boat. But tomorrow, you're each going to be in your own raft, in your own professional setting. And a couple of months from now, some of you are going to be staying very close to shore, and others of you are going to be miles off coast, because you have taken these instruments and morphed them into your own little thing. And you're going to be off script. And you're going to change the reliability of the tool. So stick to the scripts and stick to the standardized instructions. Don't offer multiple choice answers. Now, many people in public service and community organizations, social workers and nurses, go into that field because they're incredibly good people and have big hearts, like I'm sure all of you do. And we want our clients to do well. But when we're testing their brains, we want to know the facts. We don't just want them to do well. So don't give them answers by muttering them under your breath softly. Don't pantomime or act them out. Just allow people to either get them or not. Okay? So no cheating by helping people. And don't be soft on scoring. So I'm going to teach you how to score these tools. It's very straightforward. But if you're ever on the fence about whether an answer or a certain performance qualifies as a point or not, and you can't decide, is this worthy of a point or not, the answer is not. And that's because that's what makes the tool sensitive. They have to make muster, they have to follow and meet all the criteria, or they don't get credit. Okay, so don't be soft on scoring. Deduct points where you need to, and we'll show you how to do that. Remember also that these tools are not diagnostic. So there's a lot of reasons why someone could perform poorly. And again, it's not all Alzheimer's disease. Someone could not have slept well the night before or for 5 nights in a row. They may be on sedating medications, or maybe they're very significantly depressed, or they have a urinary tract infection or something else. Our job is not to diagnose. Our job is just to detect the clients who are struggling with cognitive impairment and try to get that, give them attention in the medical setting to understand what is causing it, okay? And we'll talk a little bit more about that in a second. Now, I'm going to be sharing with you information about 2 simple screens. But the screens are different from each other in an important way, and I want to help you understand what that is. One of the tools is subjective, and one is objective. So the 88 is an example of a subjective tool, and that's because this is a questionnaire. You're going to give this to a family member or an informant to fill out or to answer orally. But at the end of the day, this tool relies on their observational skills and their opinions to exaggerate its hearsay. It's hearsay. It's just someone's opinion. How accurate of observers do you think people are in the general public about what is impaired or normal? Do you think people are good at that? We already talked about how even experts aren't good at that without a tool. So family members are not always accurate. Of course, they're going to give you good information to the best of their ability, but they're limited as well. Now, this is different from the Mini Cog, which is an objective tool. This means it does not rely on opinion or someone's observational skills or hearsay. It is a direct measurement of their brain functioning. Okay? You're taking a direct measurement. And for that reason, direct measurements are more reliable. So we're giving you multiple options here, but I want you to know at the end of the day, the Mini Cog is a more direct measurement. How are you going to choose the tool? And again, I want to step back and remind you, why are we asking you to be our partners in Hawaii's dementia capability process? Why are we asking you even to know about these tools or use them? Remember what I was saying earlier this morning, we all need to be part of the solution. The healthcare system does not always do a good job of detecting these conditions. And so we could wait around until they get their act together, or we could take matters into our own hands and be part of the solution. And so that's why you're using these tools. So you're always going to administer the Mini Cog to the client that you're working with as part of your normal assessment process when you're meeting with that client face-to-face. For reasons that will become apparent in a second, you can't give someone the Mini Cog over the phone. That's because they need to manipulate pencil and paper. So you're not going to be able to do it if you do an intake over the phone. The AD8 is a tool that you're always going to administer to a family member or a friend or an informant if the client comes with someone else. So you're getting their viewpoint. So if you have a client and an informant in the room with you, you're going to be using both of these tools. The client's going to get the Mini Cog, and the informant's going to get the AD8. Okay? It's not one or the other, it's both. Now, you can administer the AD8 to the client directly if you have them over the phone. You can't use the Mini Cog, right? And so if over the phone there's no family member or friend that can get on the phone at that point to answer the questions, you can ask them directly to the client. Is that the most optimal scenario? No, because people with cognitive impairment don't always have insight. But it still opens the door to have communication and a conversation about this. So if you're working on the phone, you can administer the AD8 to a family member or someone else at home if they're available, or you're going to use the AD8 directly with the client. You following me? Okay? To say this another way, if you're over the phone, the AD8 is going to be given to an informant or directly with the client. If you're in person, the client gets the Mini Cog and the informant gets the AD8, if one is present. So let's talk about the AD8. You have this form in your packet. I think it's on the left side, but I could be wrong about that. And it looks like this. It's just a grid sort of questionnaire. Surprisingly, there are 8 questions on the AD8. That's not surprising. That's why it's named the AD8. Can everybody find it?
On the right side.
On the right side, okay. I was wrong. Right side. So remember, you can use this tool with either the informant or, if you have to, last resort, with a client over the phone. There are 2 ways to administer this form. You can make a copy of this AD8 and hand it to the informant to fill out. They can answer the questions on their own with a clipboard. Or you can read the questions out loud to them. Either way is okay. If you're reading it out loud, this is what you're going to do. You're going to say the following. Please answer the next questions with a yes or no. Yes means there's been a change in the last several years due to problems with thinking or memory. No means no change has occurred. What you notice is this tool is specifically asking about whether there's been a change, and the change has to be something that's related to memory and thinking. So this is the introduction that you're going to read. You just stick to the script. After you've read that, you'll start with question 1. In the last several years, has Elaine experienced problems with judgment? They're going to say yes or no. Number 2, in the last several years, has Elaine experienced less interest in hobbies and activities? Now, you will notice on the form, for questions 1 and 2, it does not have this little preamble, in the last several years. Why am I inserting that? Because it's recommended for the first couple of questions that you put that into the question so that the informant gets used to what time frame you're asking about. After the second or third question, you can drop that if you want to, okay? So you're just reading these questions verbatim. And basically, again, they're just covering all of these different activities of daily living. Interest in hobbies, problems with judgment, repeating the same things over and over again, trouble learning new things, forgetting the month or the year, trouble handling complicated financial affairs, trouble remembering appointments, and difficulties with thinking and memory. You're going to read these questions word for word. What do you do, though, if a family member answers question 2 by saying, oh, yes, yep, definitely, and then says, oh, wait a minute, no, I don't think so? Are you going to record yes or no? You're going to record their final answer, okay? This is like Who Wants to Be a Millionaire? Is that your final answer? It's okay for people to change their mind, so give them that opportunity. What if they say they're unsure or they can't decide? Well, what you should do is give them a little bit more time and then say the following. Well, would you say generally yes or generally no? If you add in the word generally, it softens things and makes people feel like they're less boxed into black and white. So just generally yes or generally no. If you do that, people will often pick one or the other. And you typically want someone to answer with a yes or a no if possible. What if they say, oh yes, Elaine has had difficulty paying the bills. She's had a change in that in the last year. Because she broke both of her arms and she can't write the checks anymore. Is that what this questionnaire is getting at? No. So do not record that answer because the informant is telling you about a change in their behavior from a physical problem, not a cognitive problem. So in that case, you'd say, well, do you think that she has stopped that balancing the checkbook, that behavior, because of problems with memory or thinking? If the answer is no, then that's what you're going to record. So if they give you any information about a physical issue, no, repeat the question, bring it back to memory and thinking. If at the end of the day they just say, I don't know, I can't tell you the answer to that, or that doesn't apply to her, then you're going to record the NA, not applicable response. So, for example, Elaine may never have handled the finances or paid the bills. Maybe that was always her husband's job. So she has no experience with that. So it wouldn't be fair to give her a no answer for that when she's never done that. Okay? Makes sense? So we're specifically looking at just changes in behavior. Now, the scoring of the 88 is very complicated. So listen carefully. 1 point is given for every yes answer. And there's no points given for no answers, or NAs, okay? So it's that hard. There's a total of 8 points possible, 8 questions. And a passing score is a 0 or a 1. So it's okay for people to have 1 change because of memory and thinking, but not 2 or more. So a score of 2 or more points means that this client likely is experiencing some changes in their brain that require attention. And then in that case, we should consider, as part of our care plan, getting them back to the doctor for a memory loss workup. Now you might be saying, I've worked with clients and I've tried to get them to the doctor sometimes, and they go to the doctor and nothing happens. They don't get the workup. Keep in mind that the healthcare system is changing, but changing slowly. And even if that person never goes back to the doctor, never gets a specific diagnosis, we are still informed about what's going on. We can communicate and educate the family about the cognitive impairment and what might be happening, and we can incorporate the fact that they're cognitively impaired into our care plan. Know that they might not be able to follow all of our recommendations because they have memory loss, and know what types of supports would be helpful for them. So let's move then toward the Mini Cog. So we have the 88, this informant questionnaire, and we also have the Mini Cog that we're going to use up our sleeve here. The Mini Cog, also found on the right side of your packet, and looks like this. It has some red writing. So pull that out. The Mini Cog is very simple. It includes just two parts. Part one is a list of words that we want the client to remember. And part two is drawing a clock. Now, the advantages of this tool are, number one, it's very quick. You can administer a Mini Cog in 90 seconds, on average 2 to 3 minutes. It's very easy to administer. And it measures 3 different parts of the brain and 3 different thinking skills all at once. Memory, because they have to keep track of a list of words. It also measures spatial reasoning, because they've got to space out the numbers correctly. And it measures abstract thinking, or abstract reasoning. This is because time is an abstract concept, right? And we're going to ask clients to set the time to a very specific time, which is 10 past 11. Because you don't have dementia, you know that 10 past 11 is symbolically represented by the number 2, right? 2 means 10 minutes. But someone with early dementia is losing that ability to have those mental gymnastics. And so a common clock draw for someone with cognitive impairment is to draw one hand to the 10 and one to the 11, because those were the 2 numbers that you said. Okay, so clock draw, very, very sensitive. So know something else about the Mini Cog, which is that Sue Borson, the creator of the Mini Cog, developed and refined this tool with research gathered for over 25 years. And so if you've ever seen or used this tool before, you may have seen slightly different versions, and those are old versions. This is the most up-to-date version. If you're ever questioning what the version is that you should be using, you just go to this website, mini-cog.com. That's the Mini Cog website. You can download this form. She did a good thing, which was updating and refining the tool over time. Now, I also want you to understand that all screening instruments are biased. Every single one of them. They're all biased against someone. Typically, they're biased against someone with low education, people who do not speak the majority language, English, or people from different cultures. Now, is the Mini Cog going to be your go-to tool with cultures who don't use clocks? Why not? Of course not. You're not going to use a tool that is, a whole part of it is asking people something that they don't have familiarity with. That's going to introduce way too much bias. So no tool is perfect, but the Mini Cog is less affected by low levels of education and language, English as a second language, than other tools. The research also says something really else important about the Mini Cog. If your client cannot pass the Mini Cog, they cannot reliably manage their own medications independently. They can't fill a pill box and keep track of their meds. So in 2 minutes, you're not only getting a quick snapshot about their brain function, but their functional ability as well. That makes the tool twice as useful. So you'll notice at the top of the tool that there are 6 word lists. There are 6 word lists because Sue Borson wanted the tool to be able to be used over years in a healthcare setting or in the community setting, and give people flexibility to use different lists. And so what we tell doctors and nurses is, start with list 1, but on January 1st next year, switch to list 2. That's so that people don't come in and know the same words over and over again. So we switch it up. We're crafty like that, okay? So all of these word lists are equivalent. They're all the same. And you just choose which one you want to use. I'll tell you, most people start with 1 or 2. My favorite is list 2, but you can start with whatever list you want. The words can be translated into a different language. So if that would be helpful to you and your clients that you're working with, you can translate, or a professional translator can translate the words. You can pick the list out of the 6 that would translate the best. That means retaining the meaning of those words. But translation is perfectly acceptable. Before you do the mini cog, remember, you're going to say the phrase, the next thing we're going to do requires a little concentration, so that you're priming them. And you're going to speak clearly, enunciate, and speak with a little bit more volume so that the person can actually hear what you're saying. Part 1 of the mini cog is word registration. What does that mean? It means the whole point of part 1 is just making sure that the person is hearing the words that you're telling them. So you're going to read the script. Please listen carefully. I'm going to say 3 words that I want you to repeat back to me now and try to remember. The words are leader, season, table. So choose your list ahead of time so that you can make that sentence fluid. When you're delivering the words, you're delivering them 1 second apart. Don't say, the words are leader, season, okay? That makes the test easier. It gives people more time to consolidate. That's not the way this is done. It's like a pendulum of a clock. Leader, season, table, okay? 1 second apart. Now, if the client doesn't hear all the words or can't repeat all 3 back to you, you can repeat the list again up to 2 more times. So they have 3 chances total to hear the words. So if they only tell you leader, season, then you can say the 3rd word again and have that repeated back to you. You want to make sure that they're registering all 3. If the client cannot repeat all the words after 3 attempts, you just move on, because that's a problem. If someone can't repeat back 3 words right after hearing it after 3 attempts, that's a problem. So you move on. Don't keep badgering them. After the client repeats back all the words, do not remind them that you're going to ask them for the words later. That's not part of the script, so don't do it. Don't say, okay, leader, season, table, then they tell you the words, and then you say, okay, now remember, I'm going to ask you about that later. No. If you do that, your raft will be a mile offshore. Okay? Stick closer to home. Part 2, the clock draw. You're going to turn the page over of the mini cog, and you're going to see a circle drawn on that form. Now, earlier versions of the mini cog did not have a circle. You're going to use the most current form. Why do we have a circle drawn on there? It used to be that people drew their own circle. Well, research told us the circle didn't matter. The people could easily draw a circle. That's apparently an easy skill, and so it was not something that told us very much. And some people drew a circle the size of a dime. And then they tried to put in all the little numbers in there, and guess what? You can't make heads or tails of what's in it. And so this pre-drawn circle is really for our benefit, to give us a little more visual on what's happening inside there. So you're just going to read the script. Next, I want you to draw a clock for me. First, put in all the numbers where they go, and then you stop. You allow them to put the numbers in. Now, what happens if someone just puts tick marks in? Little marks for the 12, the 6, the 3, the 9. Are tick marks numbers? No. And so you say again, please put in all the numbers where they go. Okay, so you're prompting them. This isn't a memory test. You say it again. Now, what if someone puts in all the numbers, but not the number 6 or not the number 12? Are you going to prompt them? No. You're not going to prompt at that point, because that's a failure that's important. You're only prompting if they put tick marks in, or if they just put the anchor numbers in, 12, 3, 6, and 9. Then you say, put in all the numbers. Okay? Then, once they have that done, you're going to say, now, set the hands to 10 past 11. Don't say 11:10 or 10 after 11. You must say 10 past 11. Why is that? Who knows? But research shows that language is very sensitive and important. So we stick to the script there. Did you have a comment or a question?
No, I thought it was to have them think, past makes them think back in time to try to read.
And it may be that there's something about the word past that's just a little bit more confusing to people with early dementia. Yes?
I feel like in my experience that people don't use that language, so I feel like it's a bias. Like, to say time, like, we don't use that at all here.
Yes, so the comment is we don't use that kind of language at all here, and so I feel like that's biased. In Minnesota, we don't say it that way either. And so this is how the tool is, and I promise you it's like that for a reason. And the reason is it's a little bit awkward, and that awkwardness makes people think. So don't change that. That's a very key part of the test. You can repeat the time if you need to. The clock is not a memory test. So the person draws the numbers and then says, okay, what time? 10 past 11. 10 past 11. Okay? If the client can't complete the clock drawing in 3 minutes, you move on. And that's because if they can't complete it in 3 minutes, there's a problem, and that's all you need to know. That will be reflected in the score. So don't keep going on after 3 minutes. That's just torture for you and them. After the clock is drawn, then you say, what were the 3 words I asked you to remember? And then you record the answers on the form. Again, you're not going to provide any pantomimes, hints, clues, mutters. It's just they either get it or they don't. Now, the scoring for the word list is very straightforward. There's 1 point possible for every word. There's no scoring done in the beginning of the test when they're just repeating the words. The scoring is only after the clock. How many can they remember? So they get 1 point for every word that they can remember after the clock. Total of 3 points possible. The clock is a very sensitive indicator of dementia, and therefore it is given more points. It's weighted more heavily. And so the clock is worth all or nothing, 0 or 2. Okay? Research shows the clock has a 30% error rate in scoring. 30%. So that means if you and I scored 10 clocks together, 30% of the time our score could vary. That's a problem. So what I'm going to teach you next is extremely important. These are the rules, and this is going to help you know when a clock gets full points or not. Rule number 1. All the numbers 1 through 12 have to be there in their correct location. If the number 6 is missing, 0 points. If the number 4 is gone, 0 points. That may seem very strict, but the research shows that's important. What do I mean by in their correct location? This is very simple. What you're going to do is look at the anchor numbers, 12 and 6 and 3 and 9. The anchor numbers must be in their correct locations. If another number is where an anchor number should be, let's say the number 4 is where the 3 should be, 0 points. Okay? 0 points. I feel like the soup guy on the Seinfeld. No soup for you. No points for you. If there's a 10 where the 9 goes, no points. Okay? However, if there's a space where the 6 should go or the 3 should go, there's not another number there, there's just an opening, then we give the person the benefit of the doubt. It's only if another number is replacing the anchor number. Okay? So keep that in mind. They can't have any missing or duplicate numbers, and there has to be 2 hands, not 1, not 5, 2 hands, and one of those hands has to point to the 11 and one of them has to point to the 2, 10 past 11. But the length of the hands does not matter. It turns out that there's a lot of older people who just in haste, quickly, aren't measuring the length to make 1 the hour and 1 the minute. So we don't care about the length of the hands. However, it does mean that some correct clocks are going to look more like 5 minutes to 2 than they are going to look like 10 past 11. And that's because they'll get the length of the hands off. We don't care about that. Do we care if someone puts the numbers on the outside of the circle? Is it part of the scoring rules? No, we don't care about that. So if it's not listed here as part of the scoring, it doesn't matter. What about someone gets real fancy and makes it an old-fashioned alarm clock with a bell on top? I've had someone do that. They get bonus points for artistic skills, maybe. But we don't care about that. We just stick to the scoring parameters here. Inability or refusal to draw the clock means they get 0 points. Now, this also may seem a little strict, but research shows that some people with early dementia who are aware they're having a problem don't want you to know they're having a problem, and so they're not going to be ensnared in a thing like this. And so they could refuse to do the clock. If they refuse, you can push them gently, but ultimately if they don't do it, then they get 0 points. And that is related to cognitive impairment. So a normal passing score on the Mini Cog is a 3, 4, or 5 points. So they get lots of wiggle room for normal. But a red flag or a failing score is a 2 or less, 0, 1, or 2 points. In the case of a impaired Mini Cog, then we would want to, again, connect that person back to their doctor for a memory loss workup if we can, and incorporate the fact that they have cognitive impairment into a care plan. Now, I'm going to show you a quick video, about 3 minutes, of a real patient named Sam. Sam has a master's degree. He's an educator. He has been presenting at conferences up until the last year, but his daughter has taken him to the doctor a couple times complaining about his memory. And during this visit in primary care, Sam is there for another reason. He's there to get his eye looked at. But the provider does this cognitive screening process. And so we'll watch this short video, get your reaction. What you're going to notice most is how smooth the provider is. Hi, Sam. Nice to see you.
Hey, good to see you.
It's been a while. I think your last visit in the clinic was about 6 months ago or so.
You're right.
Yeah.
Right.
Well, I hear from the nurse that you're here to talk a little bit about some trouble you've been having with your left eye. So I'm glad you came in so we can take a look at that. Before we get started with that, we're doing some new things in the clinic. You know, more and more we're looking to prevention. And so when the nurse was in, she was taking your vital signs, looking at the health of your heart and different things. And today we're also going to look at the health of your brain, okay? We call this our checkup from the neck up, okay? It just takes a couple of minutes but requires a little bit of concentration. Sound okay?
Fine with me.
Okay. The first thing I'm going to do is ask you to listen carefully, because I'm going to give you 3 words that I want you to repeat back to me.
Okay.
And try to remember them, okay? The words are leader, season, and table. Can you say those back to me?
Leader, Caesar, and table.
The second word is season, like the changes of the season.
Season, and table.
Right, you got it.
Leader, season, and table.
You got it. Now, Sam, what I want you to do in this circle is make a clock for me. First by putting in all the numbers where they go.
All right.
Okay?
Well, the way I would go it, I put 12 first, 6, 3, and 9, and then try to figure it out from there. I put the center circle, and I need I need to put 1, 2, 4, 5, 7, 8, 10, and 11.
Okay. Now, Sam.
I'm at your disposal.
Yep. Now I want you to set the time. So it says 10 past 11.
All right, 10 past 11. Well, first of all, I have to go to 10 past 11. So I'll go to 10 with that small arm,
Mm-hmm.
and I'll go to 11 with the long arm.
Okay. Okay.
What?
Nope, that's good. You're done with that now.
Okay.
Now, I'm wondering if you can tell me what those 3 words were that I asked you to remember earlier.
Wow, that's a good question. You really pulled that one on me. All right. I can't remember all 3 of them.
Okay, can you remember any of them?
No, I can't.
Okay, that's okay. Sam, have you been noticing any changes in your memory recently?
Yes, I have.
Yeah?
Yeah.
Okay. Well, I'm glad that we're talking about it
Well,
then.
one of them was season.
Season,
Yep.
you got it.
Because I mistook it with Caesar.
That's right, yeah,
Yeah.
exactly.
Yeah.
Well, I'm glad that we're having this conversation. Maybe what we can do is we'll take a look at your eye, which is why you came in. But before you leave, I'd like to schedule another appointment for you to come back so we can talk a little bit more about how your memory has been.
Beautiful.
Does that sound okay?
That's fine.
Okay. Very smooth, I heard someone say. Really a good provider, I think. So what did you notice about the interaction? Anything strike you about it? You can just blurt it out. Kind? Okay. So trying to be empathic and warm. But you also notice that I moved it along pretty quickly, you know, that this process shouldn't take 10 minutes. It should be pretty tight. What else did you notice? You notice at the end that in addition to talking about the tool, I asked Sam if he had noticed any problems with his memory. And so the use of the tool was also opening up a door to have a conversation about memory issues and his perception. And that's the case for you as well. When you use these tools, you're not just looking for, at the end of the day, what's the score, but it's an opportunity to talk about memory, cognitive difficulties, the person's own opinion. And you know, one of the things that is true, particularly in healthcare, but just culturally in general, is that there's so much stigma and fear about that type of conversation. But the more that you and I don't talk about it and keep it under wraps and don't include these types of questions in our assessment, the more we're colluding with the fear and stigma. The more we talk about it and frame it as brain health and open up these conversations, the more that we're part of destigmatizing them. Because the more that people talk about these issues, the more it will just be sort of part of everyday conversation and thinking. So that's an important role of these tools as well. So let's talk about scoring Sam's Mini Cog. This is Sam's clock. And let's go through our process of scoring. So the first thing is that all the numbers must be present without anything missing and with no duplicates. How did he do there? Good, okay. Are the anchor numbers in their correct locations? Yes, the 12, the 3, the 6, the 9 are located correctly. Are the hands placed correctly? No. You see that Sam drew one hand to the 10 and one to the 11, as I mentioned earlier, is very common for people with early cognitive impairment. Now, the clock, he got 0 points. What about the word list? Do we give him any points for remembering the 3 words? 1 point. Now, what you notice there is that Sam, on the spot, couldn't think of it, but maybe 10 seconds later, remembered one of the words. So we give him the benefit of the doubt. What if someone remembers a word 15 minutes or a half hour later? Do we give him a point? No, because that kind of slow access to information is a problem, and we want the score to reflect that. So it's only if they can come up with it, you know, within a minute or so of moving on. So for the word recall, we give him 1 point. That means he has a total score of 1, which is not a good score on this screen, right? And so what do? We're going to work with Sam to move on and have a workup. Now, Sam did come back, and we had a more in-depth conversation about his memory and did a memory loss workup. Sam has early Alzheimer's disease. So you see, again, how articulate he is, and maybe in a conversation you wouldn't detect much of a problem. He does have a problem, and the Mini Cog did an accurate and successful job of detecting it. Sam's daughter, Lydia, was there for that evaluation and the feedback and got connected to all kinds of resources and supports, but only because we did the Mini Cog. We would not have known about that without it. So you're going to be using both the Mini Cog and the 88. So what if the scores on those 2 instruments don't agree? Let's say the client performs poorly on the Mini Cog, but the 88 is totally normal. You get a score of 1 on the 88, but a 2 on the Mini Cog. What do you do then? How do you make sense of that conflicting information? Say that again? So maybe the person answering the AD8 isn't having accurate information. What you're going to do is move forward, encouraging a workup if either tool picks up a problem. Because although the Mini Cog is a sensitive, objective measure, there are cases of people who are well educated, who are very early in their disease process, who can pass the Mini Cog, but an informant or a family member who's known them for decades picks up on issues that the Mini Cog doesn't. So that's the reason for using two tools. And if you get a signal from either one of them, you're going to assume that there's potentially something wrong and try to encourage them to get connected. Make sense? So that's simple. If either one offers a red flag. What I'd like to do in this next portion here, in the next 20 minutes, is help you to feel more confident in these interactions by giving you some words, some scripting that you can use to talk to people if they pass or don't pass these tools. Would that be good to have some words to say? Yeah. Keep in mind, you're not all from the same agency or background. You're not all working with clients in the same way. And so your script may be different. This is just some examples of how you can frame the conversation. So sometimes a client may ask, why are you testing me? I know what you're doing. Why are you testing me? Well, you're going to frame this as about brain health. So you can say something like, the purpose of these questions or the purpose of this task is just to see how the brain is doing. This is the part of the assessment where we do a checkup from the neck up and look at brain health. So you add in a little bit of humor. You notice this isn't a lengthy explanation because the wordier you get, the more it suggests you're anxious and don't know what to say. So don't yap and yap and yap, because it's not that hard. This is just a brain health check, okay? If they pass and they ask how they did, then you just say, you did just fine, which is great news. So that's an easy conversation to have. You did fine, great, we can move on. However, it still opens up the door. Having done these tools opens up the door for a conversation. You can say, well, how do you think you've been doing with memory and thinking? Do you have any concerns? And if they do offer concerns, then you should take those seriously and encourage them to connect with their healthcare provider, right? So just because they passed the tool doesn't mean you don't still open up a conversation and follow up on their observations and concerns. What about if they don't do well on the AD8 or the Mini Cog? That's maybe a little bit of a harder conversation to have, or it can be. And so let's talk about what to say in that case. Now ignore, there's a lot of words on this screen, but I promise you, it's very simple. You're going to talk to them about their performance after your assessment. And by after the assessment, I mean typically after the whole assessment that you're doing. You're not stopping at each little part, presumably. You can do that. But you might say something like, the assessment that we did today, or the questions I asked today, gives me different ideas about how to help you fill in the blank. Stay healthy, keep your independence, remain at home as long as possible, whatever your goal is or their goal. And then you can say something like, one area of concern from the assessment has to do with memory and brain health. And there are a lot of reasons why someone might be struggling with memory. And then you can offer some examples. There might be a medical condition, or maybe there's a medication that's causing this, or a nutritional deficiency. And in the third bullet there, one thing that we should work on together is making an appointment with your doctor so that we can follow up on this, get down to the bottom of it, and keep you well. I want you to stay at home as long as you can. Let's get to the bottom of this. So very, very straightforward. Again, don't get too wordy or rationalizing it too much, because that's not going to help them understand the point. Again, you can use this as a door opener. Ask the following questions. Are you having any trouble with your memory? If they say yes, what do you think the cause might be? Have you talked with anyone about it? Have you mentioned this to the doctor? What did they say? What did they do? That'll give you a lot of information about where they're at and what potentially has been done or not done at that point. So with these scripts, these responses, I would highly recommend that you jot down some bullet points like those that I showed you, that you can bring with the assessment, so that you're not floundering, especially in the beginning. And so you can remind yourself of just the succinct, shortest way possible to answer these questions. Write down your script, keep it on hand. Don't be wordy, don't over-explain. And never use the words dementia or Alzheimer's disease at this stage. Why? It's completely premature. We don't know if they have Alzheimer's disease. And we don't want to scare them. We don't want to raise any alarm bells. We just want to figure out what's going on. So don't utter those words at this point. Now, you could be asked some other questions from the client, and here are some examples. What will the doctor do when I see him or her? What's the doctor going to do a memory loss workup? What do you remember from what I showed you earlier about what a memory loss workup looks like? Crickets. Come on. Yes, they might draw some labs. What else? They might take an x-ray of your brain. They might ask you some questions about what you think is going on. You know, just give them a little bit of a heads up about what the workup entails. They're going to review your medications, make sure you're not taking any bad drugs that are causing you thinking problems. What if someone says, do you think I have dementia, or do you think I have Alzheimer's disease? What are you going to say? Yeah, the tools we use today don't tell us what's causing a person's memory loss. And there are many reasons why someone might be having trouble in that area. And then you list a few. And then you say not all memory problems are caused by Alzheimer's disease. But regardless, we want to figure out what is the cause so we can do something right now and keep your brain healthy and keep you at home. That's the message. It's positive, it's brain health focused. My family complains about my memory, but I don't have a problem. Everyone my age is a little forgetful. You might hear that a time or two. And then you just join with them. You're right. A lot of people complain about their memory. And some people have a little memory loss and some people have a lot. And it's important to check on the health of the brain now so that we can make sure that you stay healthy. Same kind of message. I think I'm doing fine. Why should I see a doctor? Different version of the same thing. Why should I do this? Because we want to check on the health of the brain. And in person-centered interactions, you focus on their goal, which again is probably going to be remaining at home, keeping their independence. And that's why we want them to see a doctor. Keep in mind that when you're doing this new thing as part of your assessment, that clients can have a whole wide range of reactions, right? And they kind of fall in three buckets. There's going to be a group of people that you're interacting with who already are concerned about their memory and resonate with what you're telling them and are interested in getting answers. They just need a little nudge. There's going to be another group of people who may be surprised by what you're telling them, but are still interested and willing to move forward. And then there's going to be the third group, who are the hardest, who may not be aware of the problem, so they're forgetting that they're forgetful, or they just might not be ready to accept what you're telling them in the moment. And keep in mind that this is a protective mechanism. If I reject what you're telling me about the fact that I might be having memory problems, I preserve my dignity, my sense of being whole, not impaired, and I don't have to deal with what you're telling me. And that is a coping strategy that some people have. Some people in this room probably have that coping strategy sometimes, and that's okay. But know that the readiness to act may be gradual. It may not be today that they're willing to accept what you have to say, but tomorrow or next week or next month, the next time you interact with them, you bring it up again, they might be more willing. The seed was planted. Or you divert to a different strategy, which is, if it's in your scope of practice, to widen the circle of communication and talk to family members about enlisting their help in getting the person to the doctor or getting connected to services. So positive outcomes in using these tools are still possible and still happen, even when people are a little bit reluctant at first to accept what you're telling me, or telling them. Make sense? Okay. So as we close this section, I want to just tell you also that there are people out there who need help going from these screens to actually connecting with a healthcare provider or accepting the resources that you are recommending. And you can help to make that connection possible and happen sooner if you do a little bit of assistance. And again, within your role and your scope, and it may be different among you, but the more you can do, the more likely it is that they're going to follow up. So if you can sit in the room, if you're doing an in-home assessment or in the office, while the family member calls to make an appointment, that's great. You could offer to help broker the call, help make the call, make the appointment for them. You could say, I'd like you to make this appointment, family member or client, and I'm going to follow up with you next week. I'll give you a call to check on progress, to make sure it happens. Or you could go with them to the doctor if that's something that you're willing and able to do and they're willing to accept as well. Again, your focus is promoting positive, brain-healthy messages. You want to encourage the involvement of the family member if you can, for obvious reasons. As a provider in a clinic, we see a lot of people who present alone, and it's pretty hard to make heads or tails when the person is saying they don't have a problem. We suspect they do, but there's no family member to give us the real scoop on what's happening. And family members, you can tell them it's okay to write down on a little piece of paper 1 or 2 or 3 things that you want the doctor to know that you're uncomfortable saying out loud. So some family members don't want to say, huh, my gosh, is she ever forgetful? You can't believe what she's doing. They don't want to say that. It's hard on the relationship. And so they just jot down some pieces of information and hand that to the doctor when the doctor walks in. I get that all the time. And it's a very nice way because I just discreetly look at it and then I've got some heads up. The family member knows what's going on and that makes it a lot easier. So you can coach the family on ways to communicate with the doctor. And then ultimately you're going to close the loop. You can say something like, I'd like to see you or talk to you again after you follow up with your doctor about this. Does that sound reasonable to you? So you want to encourage that closing of the loop and that kind of follow-up. Lastly, I will just mention that there are some sample letters in writing that you can give to clients or family members that help to summarize your recommendation after using these tools. And you don't have to use these. I just want to share that they're available, and they're available at this actonalz.org website. You can go on there, download it, put your own logo on it, change the wording if you want to make it suitable for your needs. But this is an example. These are pieces of paper you would just carry with you that you could fill in the date and the client name. And the first paragraph just says, hey, as part of our health assessment today, we looked on the health of the brain. And the second paragraph says, there are many reasons why someone might be having some memory problems. The third paragraph says, we want to keep you well, and so it's important to get a checkup. And then the fourth paragraph says, I recommend that you talk to your doctor about this, and then has your name. So sometimes it helps to have something in writing for the client or the family. Now, there's also a different type of form that I'll give you a heads up about. On this form, also available at the same website, the client signs their name, giving you permission to pass on some information to the doctor so the doctor knows, or the nurse practitioner, or the PA, knows what has already been done. So the top part is just who they are, and then they sign their signature there. This is HIPAA compliant. And it allows you to fax or send or bring this over to the clinic. In the middle, let's see if I can get the mouse, you would just check this box here, Mini Cog, that's the tool you used. Here you would put the score. So if this was Sam, we'd put a 1 out of 5, that was his score. And then you might write a little notes here, like Sam's daughter has also been concerned about memory. I'm worried about a possible dementia. needs a memory loss workup. And then you can check some other boxes here at the bottom that communicate other things to the doctor. Now again, this is HIPAA compliant, and it's something that you and your organization can consider using. It's very helpful for the health system to get something like this because it shows that people in the community are on it, and they're already doing this work, and now we want the health system to do something about it. Before we break, I want to just mention one other thing. Back to the point about sometimes even when people go to the doctor or the nurse practitioner or the PA, the healthcare provider doesn't follow up. Maybe they'll say, oh, you're just fine. They don't do anything. Does that ever happen here? Maybe a little. What you can do is empower the family to do one thing when they go to the doctor. And that is to tell the family member to request that the healthcare provider do an objective cognitive evaluation. Just ask for an objective evaluation, a tool, a screening tool to be used. Because this helps the healthcare provider to know, this person's informed, they know what they're doing, and it puts the doctor on the spot. And if the doctor or his nurse or her nurse does the screening instrument, they're going to find out that there really is a problem. So that's the one thing, if you can coach families to ask for, is an objective cognitive evaluation as part of the memory loss workup. Because if the healthcare provider does that, the rest will likely fall into place. In the meantime, again, the point of incorporating these tools is to raise the bar and to enhance the community on this island and all the islands to make sure that as a community we're as prepared and as competent as possible for dementia, and that we're all the eyes and ears helping each other out. We, I think, have a couple of minutes, 5 minutes actually, before our lunch break. And again, I'll just stop because we've covered a lot of ground regarding the Mini Cog, the scoring, the 88, how these tools are used. Does anybody have any questions at all about how to use these, how to talk to people about it, or what-if scenarios that you want to throw out? Yes?
What if there was like a clock or the person had a watch on?
Okay, what if there's a clock in the room or the person is wearing a watch? What do you do then? What I would do is ask them to take their watch off or cover it up, or if there's a clock, ask them explicitly not to look at the clock without looking at the clock on the wall, and then give the instructions. Now you can't force them, so if they happen to look at the clock or their watch, then you just let them do it. But know this, people with early dementia who look at clocks and watches still have trouble completing that task. So don't let that be too much of a barrier, because you should be mindful about it, though. It's an excellent question. Try to stop them from doing that if possible. Another question in the middle here. Yeah, so you saw this a little bit with Sam, didn't you? Which is that he repeated the words once and then he did it again because he was trying something similar, a strategy. If I just keep saying them, then I won't forget them, right? So brilliant strategy, very good strategy. What should you do?
Can you repeat the question?
Yeah, the question is, thank you, the question is, if someone is doing the Mini Cog, you give them the 3 words to remember, and they just keep repeating them over and over again, even while they're drawing the clock. So they're repeating the words to keep track of them. And then when you ask them for the words, they just keep repeating them again. So what do you do? What do you do? Any guesses? Do you allow them to do that or not? You stop them from doing that if you can. They can still do it in their mind, but you need to say something like, please don't repeat the words out loud. Please don't repeat the words anymore out loud. So you make that request. They may not listen to you, but they probably will. But that's a very good strategy. I might use that when I am given the Mini Cog. I like it.
We were both laughing so hard.
Yeah.
It was really kind of humorous.
It's
I didn't correct her. I just.
Yeah. So in the future, correct them. Stop them from doing that. Yeah. They're sort of cheating, although in a crafty way. Yes, in the back of the room.
How often do you administer the Mini Cog with a
Yeah, so how often are you going to administer the Mini Cog with a positive screen? The Mini Cog is meant as a detection tool. So if you use the Mini Cog and ideally they go to the doctor, they get a diagnosis of mild cognitive impairment, Alzheimer's disease, Lewy body dementia. Do you need to do the Mini Cog again the next time you do an assessment or the next time you see him or the next year? No, because the Mini Cog has already been done. It's done its job. It's detected a problem. End of story. So if they already have a diagnosis, you don't need to use that anymore. Okay, does that answer your question? Yes, so they have a positive score 3 months ago. Maybe they didn't follow up, or they did follow up with the doctor, but nothing was done. You're swinging back again through the door 3, 6, 12 months later. Do you administer it again? You have a choice in that case. You certainly can administer it again because they don't have a diagnosis yet. And if you feel like doing so would help, either to increase the family's awareness, to open up a conversation again, you can. But you don't have to. You can also forego using the tool and simply bring up, have you noticed any changes with your memory? Open up the door again for conversation with the client and try to talk more with the patient's family, the client's family, about getting into the doctor or connecting to resources. Did that answer your question? Okay, good. Great question. Very good. Yeah, excellent questions. You're right. Sue Borson, when she first made this tool, she gave providers a lot of flexibility to use any words that they wanted. And there's a benefit to that, but there's also a major disadvantage. And the major disadvantage is, number one, every provider then is using different word lists. And number two, some people are picking very easy words, maybe some words that are related to each other, and other providers are using very difficult words. And there was too much mixing up and lack of standardization, and so that's why the tool was changed. So don't use those old words. Those old words are much simpler than the ones that are used today, and that's a problem. So the words that are on the list now are a little bit higher level and less commonly used every day. Your second question was, there used to be another part of the test that was left out, and yes, that was taken out because it didn't add any information. The clock and the word list was enough, and she was trying to shorten the tool. When we bring these tools to docs in the clinic, you can imagine that one of the things they're concerned about is time, because they only have minutes face-to-face with people. And so even a screen that takes 10 minutes or 8 minutes or 7 minutes is just too long. And so that was another impetus for her. If she lobbed off that part of the test, it made it a minute shorter. Yeah, that was a great question. What else? Any other controversies, challenges? Yes. Yes, so have I ever worked with somebody or given a Mini Cog or something where they didn't do well, but maybe they live alone or they don't want their family involved, they don't want the doctor told about it? Absolutely. Yeah, that happens. And what I do in that situation is keep trying to come back to the person's goals. So if they want to stay at home independently, for example, I still incorporate the information, bring in services and supports that they will accept, and keep trying to nudge them along slowly. It's a process, and sometimes you're going to have more success than others. I mean, I want to be honest with you and direct, and you know this already, that these detection tools aren't going to necessarily magically help everybody to get what they need. It's just a starting point. So yeah, I encounter that all the time, and sometimes I hit a roadblock and, like you do, and have difficulty. Michelle, were you going to say something? Yeah, what Michelle is describing is something that really does unfold slowly over time. Slowly. And she's also talking about sort of getting their agreement to communicate with the doctor before you get into all these different pieces of the assessment, instead of them doing the Mini Cog and then afterwards saying, oh, can I share this with the doctor? That may be a little bit more threatening. But at the end of the day, there are going to be people who don't want that information shared. And then you just do what the rest of us do, which is you still put your heart and soul into trying to help them in other ways that are possible. But that's a reality and a challenge. This is just a starting point.